All right, after much thought, I've decided that rather than doing one chapter review at a time, I'm going to do the entire week's worth of chapter reviews. So it's going to be like chapters 1, 2, and 3 for week one. And then this will be our comprehensive overview. I called it comprehensive overview 1 for Intro to Pharm because this is going to be a complete summation of all the material prior to our first examination. It's a lot more slides, but I feel like it's going to be far less daunting because I'm not going to have to keep shoveling things your way. Like, hey, just posted a new one for supplemental learning, but it's not mandatory, but you're going to need it. Like, it's weird, right? So if I just do one video and I'm like, hey, you need to watch this, period, because we're not going to be able to cover everything in lecture that we're going over, I think this will be easier for you. So just let me know what you think about it. I think this is a good idea. I think this is going to be a lot less stressful. But maybe I'm wrong. So, again, your feedback's everything. So let's jump into it. It's probably going to be the upwards of 70 slides. I'm still working on it as I go. So I'm just trying to chip away little piece by piece. So, all right, let's do it. Y'all listen to the words that are coming out of my mouth. Subjective data and objective data is going to be hot testable material. Period, point, paragraph. You are going to see this on your NCLEX. You're going to see this on your HESI. You're going to see these in MedSurg 2, MedSurg 1. It's going to be in your fundamentals. It's everywhere. It's everywhere. So I need for you to understand how serious this is. And I need for you to get with it real quick because this is fair game for our exam. And you know I'm going to hit it if I'm talking about it. All right, cool? So subjective data, it's what the patient states. It's what the patient's family member states. All right, it is subjective, which means it is subject to probably being incorrect. Why? Oh my God, you don't even think about your patients. How could you be teaching this? No, it's not a matter of not trusting my patient. Please don't get it twisted. I believe everybody in this world is truly equal with very few exceptions, right? So what I mean by that is I'm a subject matter expert in my field. But you are a subject matter expert in whatever field you are as a patient. So if you are an auto mechanic, I'm not going to come up to you and try to clock you on things related to mechanics of an automobile because I'm going to end up using stupid words like thingy, right? So this is why subjective data comes into play. Unless you've had 14 years of unencumbered 24 hours of understanding what it is to be a part of this team we call medicine, right? You don't understand the ins and outs of the corresponding correlating factors relatable to why you know what you know. You know, that savoir faire. So please understand, it is subjective because the patient more than likely does not have the proper background to understand what it is that we do for a living. And even if they were, if they're in the hospital, then what that is subject to be impaired because their perception in a hospital setting with them being sick is not going to be favorable and they're not going to be rational. Hi, how you doing? So some examples of this. Description of what they believe their problem is. All right. I've had this headache for 2.5 weeks. No, you're actually having a stroke. All right. Subjective. Again, it's a matter of know-how. It's a matter of not having the education, a matter of ignorance. It's not a matter of less than. Please understand, hierarchical scale does not belong in my brain. It just doesn't. It never has. It never will. I've come across some really, really important people in this world. I've treated them just like my uncle because it's just not like I don't know if it's autism. I don't know what it is. It's just not there. And I'm totally cool with it because it gives me a nice little hindsight on everything around me from a completely different perspective. And I see things that most people don't see in an average day. Again, watch these nuances because this subjective data is still very, very important. All right. Because we can tell if someone's cognitively aware. If they're giving me legit information and backing it up with numbers. Hey, listen, alert and oriented times 3. I don't even need to do a test. Duh. We got advanced cognitive processing, executive function. I'm finished, all right? See how imperative it is. Statements regarding what helps the pain or what makes it worse. A lot of times people think that heat is better for their pain, but the type of pain that they have is an inflammatory response. So by putting heat on it, you help inflammatory markers and it swells worse. Yeah. I cannot make these things up. A lot of times we put heat on it because mama used to put heat on it and grandma used to put heat on it. And that makes us feel better because from a, psychosocial perspective, that puts me in a great place. And that Pavlovian response says, all better. But you can't seem to get your knee fixed because you keep swelling it up. So you need ice. things like that. Okay, again, this is considered subjective. I think I've beaten it until it's a dead horse. So let's move on and let's talk about objective very quickly, and then we will blow through that. Remember, this is testable, this is fair game. Okay, objective data. Remember, there's only two types of data. Note that it is underlined, italicized, and bolded. There are only two types of data, subjective and objective. There are no other options in the world other than subjective and objective for the purposes of this class in nursing. So, objective data. I say objective data provides me an object to measure and prove that that is accurate. All right. That's how I put them together. Subject, you are subject to be probably wrong, right? And objective is there's an object that defines what it is I'm stating is accurate, okay? So objective data, it can be seen, it can be heard, it can be felt, it can be measured, all right? So +2 pitting edema, that is objective identification of information, as I am a medical professional who has been trained on how to do that, and I am a subject matter expert by all accords. I will know what +2 pitting edema is, whereas something else isn't, because I am a measurable device, if you will. All right. A Dynamap, or what they call a vitals cart, is going to give you vitals measurements. Again, objective data. Imaging, objective data. Calling a physician's office and getting a history of present illness or a history of anything, or of medications. Objective data, again. Subjective is, I've had a headache for a couple of weeks and I'm the patient, or I'm the patient's family member, all right? So I think we got that, and now we'll move on. All right, so let's talk about drug schedules. There are 5 drug schedules, and this is pretty aggravating to look at already. So let me quickly explain this. There's actually a hack for this. It's one of my brain things that I do where nothing makes any sense at all why I'm doing what I'm doing until I do it, and you're like, oh, that actually works really well. I'm going to remember it that way. All right, so this is my first little grand jeton your way. All right, so Schedule 1 medications. So medications where there is no accepted medical use for treatment in the United States. All right, so heroin, LSD, marijuana is not exactly accurate anymore, ecstasy, and peyote. All right, cool. So how would I remember that that's a Schedule 1? Well, it's pretty simple. 1 looks like that, and then, oh my God, eek, it looks like an exclamation point. So that's nobody's getting in the door. Done. All right, cool. Schedule 2, high potential for abuse and can lead to psychological or sociological dependence. All right, cool. What do I do about that one? All right, well, high potential, Schedule 2, do like that, and it makes an H. That's so lame. But hey, guess what? It works. I don't even want to hear it. All right, cool. Number 3, Schedule 3, moderate to low potential for psychological or sociological or physiological dependence. All right, cool. It's the number 3, and guess what? You put a line there, and you put a line there, and it's an M for moderate, okay? Or there's 3, which means there's 1 in the middle. It's right there. So I don't care how you look at that, but either way. And then Schedule 4 is low, and it kind of looks like if this were to knock into that one, then it would turn into just an L. Right? And which is really weird, and I get that. And then this little buddy right here is just perfectly fine because this is actually a less than symbol that has just been knocked at a 6 o'clock formation. So it is the lowest of the low. It's so lazy that it's just sitting up like teetering. All right. So that's how I would remember that. Usually with scheduled drugs, the question you usually get is regarding Schedule 1, which is the lowest, which is Schedule 5, and what medications are correlated with Schedule 1 as well. And then somewhere in the middle, we play the game of Schedule 4 medications. I rarely see 2s or 3s. However, it may be a thing. But for your level, I would say no, the basic top medications of each schedule. So like Schedule 1 heroin, yeah, that's never happening, right? Done. And then knowing that there's no accepted medical use for that whatsoever, period, because that's common sense, guys. All right. And then 2, let's see, I see meth, OxyContin, Adderall. All right, these are medications we can play with, but necessarily are not a smart idea. All right, cool. So that's high potential for abuse. Yeah, that makes sense because cocaine's there, right? I figure you guys can figure these out pretty quick. But know that that might be a thing because I've seen this on standardized tests. I've seen it on HESIs. I've seen it on NCLEXs where they ask specifically about a schedule of medication. So keep those in mind, and that is your job for this slide. All right, next one. All right, here we go into the system where I love the United States and I come from the United States, and that's fantastic. But when it comes to math and converting pounds to kilograms, it's like pulling teeth, and I just don't understand why. All right, check it out. This is the easiest way of doing this. Ready? 1 pound, cool, is literally 2.2. This is how I need for you to remember this. All right, ready? So for every kilogram, it is 2.2 pounds. Every kilogram is the equivalent of 2.2 pounds. So, how does that work? Well, it goes a little something like this. Your kilograms are the bigger number. Yup. Because it's 2.2 pounds, which means it's heavier than a pound. And your pounds are the smaller number. Cool? So, if I have a low number and this is somebody's weight and it's an adult and it's 70, I know that is kilograms because I do not know many adults in this world that could be 70 pounds and still be a moderately functional patient. Okay? So by default, I know that that's kilograms. So how the heck do I figure out what that means? Well, in this case, if I'm at kilograms and I need to know pounds, well, I just multiply by 2.2. See how that works? Okay. So, if I need to go from kilograms to pounds, I just multiply the kilograms by 2.2. And you're going to get around this number. Now, the reason this number is just a hair off is because their formula from a metric system perspective equates to like 2.2034. We're not doing all that. We're doing 2.2 and we're leaving it alone. Got it? Cool. All right. So, again, if I have, let's say I'm 190 pounds. Well, how do I figure that out? Well, that's easy too. Because what I do is I do the pounds and then I divide by what? Yep, 2.2. Done. That's your kilograms. See how easy that is? For whatever reason, this always stumps people because they always do it backwards. And I've never understood why. It doesn't make any sense. If you have a higher number because it's pounds, so like 190, and I need to get kilograms, which is a bigger unit of measurement, I'm going to have a smaller number, duh, because there's going to be less of the big thing and more of the little things, which is why pounds is a bigger number than kilograms. Y'all got this. Y'all can do this. I got faith in you. So, big number makes sense, 235 pounds. That sounds about right for an adult in Ohio. Cool. I need to know kilograms divided by 2.2. All right. Said person is now 90 kilograms. And they are a 58-year-old male in Ohio who is 6'2". Yeah, that's a kilogram number. I need to multiply that by 2.2, and we're done. That's it. Over. All right, you're gonna get a question about this. You are gonna have to convert this. There is no way around this. It is gonna happen in standardized testing, HESIs, the whole shebang-a-bang. It's going to be on, before you start a clinical day, you're going to have to do like a math sheet and you have to get 100% on it. Like this is going to be on there. I'm just letting you know. I got no reason to lie. So commit it to memory, go over it. If you need to, watch it again. If you're still stumped, give me a call. You got my cell phone number. Send me a text. We got this. All right, next slide. All right. In medicine, we have to convert things. A lot of times we have meds available in milligrams, right? But we need the medicine in micrograms. A lot of times we're going to have this as a measurement of grams, but we only have available milligrams. So we're going to have to convert this over in our brains. Now, I'm going to bring visual aids for tomorrow. We are going to play with these things physically. Do not stress over it. But I need for you to know this is one of the calculations that most people miss because this is a basic equation with a very, very basic idea. And I don't know what it is about it. Maybe it's so easy that it bothers you and you guys get nervous, but you guys always miss these questions. So we are going to go over them in class. I'm not going to get a whole bunch into this slide. What I will tell you are these things right here. If I need to go from kilograms to grams, all right, then at that point, what that means is it's a unit of measurement and the difference is 1,000. All right. So if I've got 1 kilogram, and this is my imaginary dot right here because everything else is theoretically just a group of zeros that just goes on like the song that never ends. All right. What I do, very simply, y'all ready? There's 3 zeros. There's one, there's two, and there is three. All right, cool. 3 zeros. Here's how we do this. Ready? 1, 2, 3. And then my new decimal place moves here. And that means that 1 kilogram is 1,000 grams. Y'all, I know that y'all didn't know nothing about that. See how easy that is? Now, we're also going to do the same from grams to milligrams potentially, or we're going to do it from milligrams to micrograms, like the slide says. So we will go over this in class. That is the easiest concept on the Lord's green earth, and I know it bothers everybody, but just trust me. These are easy points that you can miss, and I do not want you missing these points. I don't want you missing them on your HESI or your exit or, oh Lord, your NCLEX. I don't want you missing any of these. And it's going to happen, and it's going to come back over and over and over and over. Okay? So just get that much in your head and understand that simple concept. And that same concept is going to go from here to here. It's going to go from here to here. And it's going to go from here to here. All right? And sometimes we have to go all the way from here all the way to here. And I feel like John Madden right now. But here's the beauty of it. All we just do is just add 3 zeros here, and then 3 zeros here, and then 3 zeros here. And you're still going to come up with the same daggone number. It's just going to be a matter of how many zeros is at the end. Okay? Long story short, don't trip over it. We will talk about it in class, and we will move to the next slide. Okay. So this is about conversion of tinctures, conversion of milliliters to ounces, ounces to milliliters, things of that nature. Now, why is this important? When we're doing intake and output on patients who have, I don't know, congestive heart failure that's so severe we have to give them a certain amount of water that they can drink, and beyond that they can't have any more. We're constantly pushing Lasix in them, or we got them on a Lasix drip, or we've got them on a situational drip that's a close derivative. Whenever we're doing something like this, we have to do constant I's and O's, or we are in so much incredible amounts of trouble, because this could kill a patient very quickly, right? So we have to know these conversions. So I gave you a really, really nice chart over to the right. Is that the absolute chart? Nope. Are there bigger ones? Yup. How big did they get? Well, go to the TikTok channel, because I got about 4 or 5 of them in there, and they're all really, really good. And I do them over and over because I like to just keep throwing them in there for people, because I know how important they are. These conversions are always going to come back at you. Again, we are going to make tinctures on class. We are going to have measuring cups and spoons, and you're going to put it all together, and you're going to have water play day like a bunch of toddlers. And the reason I want you to do that is I want you to visualize it. I want you to hold it in your hand, because at that point, you know what it's like. You can see the 3-dimensional nuances of it. So you commit it to your long-term processing of your brain a lot easier. I don't do child games to make you feel like a child. I do it because it puts you back at a time where you have a moment of repression, where you go back to a space that was comfortable to you. And in that comfortable space where you were learning and growing and having this nuance of a journey that is your existence, you felt comfortable. You felt like you had the ability to be sociable. That is your space that I need to be in for your brain, so that I can then pad in this information at the heightened point of your learning existence, with your brain growth. Do you see how I do that? Like, I do stuff because I'm smart. I don't do stuff because I think it's fun. I tell you it's fun because, well, at that point I'm a space cadet to you. So, I'm a little bit easier to deal with. But the truth of the matter is I'm really thinking about how to tap into your brain and get you to commit this long-term processing. Because again, this is going to come back over and over and over again. And you will see this on all of your tests from here on out. So this is your first chart over here to the right. The ones I want you to focus on. 30 milliliters is an ounce. You need to have that committed to memory, because when somebody eats, somebody eats a pudding cup that's 4 ounces, you need to be able to convert that over to milliliters. Why? Well, because I also gave them 500 milliliters of a bolus of fluid because their blood pressure was low. I gave them, another 151 units, which is another 8.8 milliliters, right? And I need to subtract that from the 500 milliliters that they just urinated. You see how hectic it gets real quick? So make sure that you understand those two conversions and also 5 milliliters in a teaspoon. That's also super important because it also relates to tablespoon. Tablespoons relate to the next measurement up and so on and so forth. So when we're dealing with pediatric medications, a lot of times we're going to use a syringe and we need to know that 5 milliliters is a teaspoon, right? And we also need to know that 15 is a tablespoon. So little things like that. And I think we got that covered for this slide. So we'll go to the next one. All right, when we are talking about brand or trade names, we have proprietary and non-proprietary. Proprietary just means property or ownership of something, right? So we have a brand trade name, and that brand or trade name is known as, Tylenol. So that is the name that we know it by its specific company, right? And it's only ever one company. Generic, however, generic is going to be the most commonly used name. A lot of times it's the medication that actually activates the change in the patient. So, like acetaminophen, which would be the same equivalent, right? So, generic name is the one that everybody knows by its basic chemical composition or its active ingredient, whereas the brand or trade name is the proprietary name, or the property name used by people who own that trademark. Okay, so chemical names not usually used outside of the laboratory setting. If you have any questions about this, Pharmacopoeia is a great resource. It's going to have it's going to be like your drug guide Bible, if you were. So that would be that resource. And make sure that you understand the difference between a brand / trade name or a generic name and what that specifically means, and be able to understand and recognize that if it requests a brand or a trade name versus a generic name. All right, we're going to have to do this slide my way because there's no other way to explain this and get you to potentially comprehend the complexity of all these definitions I'm about to give you without doing it just kind of in the generic type of way that I do it. So here we go. Just hang with me for a second. All right. So I need for you to think about an annoying little brother, an annoying little sister, or an older, I don't care, whatever, or just that person that just nags you to the point of you think to yourself, man, I'm glad you're pretty, because down a flight of Nerf stairs you would go if you weren't, okay? Like, I'm just going to need for you to just like peep that in your brain for a second. All right, so this little brother symbolizes what I call the medication that is the antagonist. All right, let me explain. So what it does is it attaches to the receptor sites to block the normal response to the cell's body chemicals. What the heck does that mean? What that means is that annoying little freaking brother, you're over at the grocery store trying to talk to the bag boy because he's looking good, right? Like, you know him, he plays football, you're a cheerleader, it's a thing, right? So you're like, hi, this is perfect, right? And here comes your annoying little brother and totally blocks you with, I don't know, a box of preparation H, and it's like, here, did you forget this? And then it goes down the conveyor belt, and you look at this bag boy and you think to yourself, why, and all that is good and in creation did this just have to happen, right? That would be the equivalent of an antagonist medication. Please understand that. Please understand that. All right. Let me bounce over to the agonist, and here's why. Because just like you need to understand the antagonist, which is the annoying little brother that completely ruined your chance. And no, by the way, I don't have a little brother. I know this never happened to me. I would just imagine in my head that would be one of the more embarrassing things to deal with as an adolescent. All right, so cool. So now that I got that, the agonist is a little different. So it activates receptors and it has the same actions as the body's own chemicals. So let me explain this. This would be the equivalent of that annoying little brother doing that reaction and me hulking up with the bowels of anger and anguish that I have from within, right? The rage of the Titans. I summon thee. And now I'm in like beast mode, right? Because I have just pumped my adrenaline, right? This would be what an agonist does as far as medication is concerned to you. Does that make sense? Hopefully that makes sense. All right. So sympathetic drugs, all right? These are medications that will trigger a sympathetic and a parasympathetic response. Now, I'm going to have to explain this one in class because sympathetic and parasympathetic responses are very specific. And the beauty of sympathetic versus parasympathetic is if you know what's going to happen, you know what reaction they're going to have. So you know what symptoms to look out for and you know how to immediately combat it. How do I know that? Well, because the world has a balance, and if one is low, then to combat that, we have to have one that is high to the opposite of the extreme so that we can meet in the middle and have balance or homeostasis, right? Like big words for everything's copacetic. All right. Hey, that was a funny sound. All right. So that is the idea of a sympathetic drug. And again, sympathetic versus parasympathetic. I feel like I just need to teach you in class, but lo and behold, we're going to have to explain it anyway. So here's the deal. I want you to think of like the 80s slasher movies, right? Freddy, Jason, those guys, Halloween, whatever. I want you to picture those guys running and charging after you, right? With the speed of sound. And you were trying to run from them, all right? This would be considered a sympathetic response, sympathetic nervous system response, because think of sympathy, think of being sad, think of crying, right? Because someone just passed. Well, guess what? If those guys catch me, I'm going to be no different. Okay, so sympathetic response, what does that mean? That means my pupils are going to be incredibly dilated because I'm going to be looking around trying to make sure I don't fall over a twig, break my leg, and then I'm crawling to my demise, right? Because I'm that person in that slasher movie, all right? Heart rate, incredibly high. I'm going to have tachycardia. Why? Because I'm trying to blaze away from these clowns behind me. Quite literally because they're Stephen King's It, and I just remembered that. So there's a whole nother wave of emotions right there. All right, cool. Let's keep going with that. Respirations, they're increased. Duh, everything's increased, right? Blood pressure, we're kicking it up into high gear, things of that nature. Rationale. Am I a rational person when I have this going on? Heck no. Why? Because while everything else is on full alert and it's going stupid like Cupid, and my peristalsis has immediately stopped, my intestines moving because I don't have time to poop or pee. I'm going to be getting slashed here in a second. Well, all of that is going on. My body is trying to combat those fears by, again, charging away from it. Now, let's stop. Let's do the reverse. Parasympathetic. That means I'm drinking a Mai Tai on the beach, right? Because I'm chilling like a villain who just had their penicillin, right? So there's no more illin. That was lame. I know. Just keep going with it. So parasympathetic responses are I'm resting and digesting. My heart rate is lower. My blood pressure is lower. My respiration rate is back to normal, things of that nature. Okay, so you need to know the two opposites of the extremes because how do you combat one with the other, right? So if I am too hyper sensitive and I'm in the sympathetic nervous system response, what do? I get you something to calm your little self down and put you back in a parasympathetic state. What happens if I'm too parasympathetic, right? Like I've got a pain pump and I've been hitting it like a crazy person and eating those Percocets and now my respiration is 10 and I'm hyper parasympathetic. What the heck am I going to do? Well, we key you up and G you up and then we go back to the highs, right? And then we find that happy middle. So that's kind of how that works. And that's sympathetic drugs. And then we have mimetics. And mimetics are meant to act like normal responses in your body, kind of like hormones. A good example of this would be like an incretin hormone, like a glucagon peptide or GLP-1, right? So Ozempic is a good example of this because it basically mimics that, which is why it looks like mimic because it's a mimetic, right? Hi. That's how that works. So it basically mimics the response that you would normally have in your body had you not had a deficiency type of a deal, if that makes any sense. Know the difference between these kind of meds because you were absolutely going to be asked. All right, next slide. All right, let's talk about the different type of medication effects really quick. There are expected side effects, there are intended therapeutic effects, there are idiosyncratic effects, and there are adverse effects. And we're going to talk about all of these things very quickly, and we need to know the definition of all of them, quite honestly. So an expected side effect is one that is not intended, but it's also not unusual. So if you take a bunch of acetaminophen and you get a bellyache, that is considered an or an expected side effect that was unintended but not unusual to people. Maybe you need to have a bite to eat first, right? So a prime example is Benadryl is going to make you sleepy potentially, or maybe not. Right? Again, it's an expected side effect. It's not meant to be that way, but if it happens, meh, whatever. All right, intended therapeutic effects are how we expect the medication to help the patient. So I have a headache. The intended therapeutic effect of acetaminophen is the headache goes away. Done. Right? Now, when we get into idiosyncratic and adverse side effects, they're nearly the same. Here's the difference. Idiosyncratic, idio means from self or separateness from a Latin perspective. So idiosyncratic can mean the separations of extremes, aka I don't get enough of an effect from that medication or no effect at all, or I get way too much of an effect and then I feel like bonkers, right? That's idiosyncratic. This is different from an adverse effect. An adverse effect is a harmful, and undesired effect from a medication, a procedure, interventions, things of that nature. So it is something that is unwanted and is harmful to the patient. So adverse effects are different than idiosyncratic effects because idiosyncratic effects could just do nothing at all, right? Like I could take it and be like, it doesn't help or hurt. It physically does nothing. Or I could take it and it can make me loopy like Doopy. And then I'm like, no, I can't. Loopy like Doopy and I feel like Snoopy. Like I can't hang with that. So please understand the difference of definitions because you might have to recognize one of them. Okay, cool. All right, just so we get all this straight in our head, I wanted to make sure that we understood the difference in all of these terminologies. All right, so we got pharmacodynamics, we got pharmacokinetics, we got pharmacology, we got pharmacotherapeutics. All right, everybody calm down. All right, literally listen to the words pharma, medicine, dynamics. All right, dynamics means how something works, right? What makes it work. So again, the effects of the drug on the body. How something works on the body. Pharmacodynamics. Cool. Pharmacokinetics. Kinetics means movement. You know what else means movement? Metabolism, because metabolism creates the ability to move. See how that works? Because of the action potentials in the adenosine triphosphate or the ATP. That's why I never worry about zombies, because zombies can't create ATP. AKA cannot create metabolism. Therefore, it would never happen in a million years. I'm so sick of talking about it. I'm just telling you. Pharmacokinetics. Kinetic machines move, just like metabolism helps you move. See how that works? Pharmacology is the study of drugs. Got it? And then pharmacotherapeutics. It is how we use medicines for therapeutic treatment of a disease process. You need to know those definitions. I'm going to make you point one of them out. I think that's fair. And it's easy points. All right, herbal medications. There's quite a bit to learn about herbal medications, and we're going to talk about a couple of them and what they can do. Herbal medications are not what you think. A lot of times they can cause more damage than they can do help anything. But because it's like trendy, then we jump on these trends and we put ourselves in a situation where we make things worse than better. Yeah, because we decide Dr. Google went to med school. He didn't. He's AI. I'm just saying, like, it's a thing. They don't feel, and that's kind of problematic when you're dealing with people. I'm just saying. All right, cool. So herbal medications, the Dietary Supplement Health and Education Act of 1994. Basically, it says you have to label the effects of the herbal medication, and also tell me what it does to the structure of your body in the cellular, from a cellular level. What does that do to my brain? What does it do to this and that and the other? They have to, because before it just used to be like, hey, snake oil, get your snake oil. Step right up, bitch, your snake oil. Come get your snake oil. It takes care of polyurethane problems, furniture, and mustaches. Like, I'm just telling you, it's the thing. So you have to have information about the structure. It is required due to this. And also herbal supplements are considered food supplements. So make sure that you know those 3 points. And we're going to get into herbal meds here in a bit and talk about why it's such a big deal if you are stacking on top of them with polypharmacy. All right, so this is echinacea. I'm going to do it again. Echinacea. I know it looks like echinacea, like it's echinacea. All right. So here's the deal with echinacea. This is a herbal medication, herbal remedy, whatever. Back in the Roaring '20s, echinacea was used for influenza type situations. We had a really nice influenza outbreak, I want to say in the teens and 20s, that went pretty nastily, if I'm quite honest. Wipes out a whole bunch of people. But for whatever reason, echinacea became the thing. Well, dial it down, and for a while, nothing happened. And then into the late '80s, early '90s, boom, we come back up again because we did some studies and remembered that we used echinacea, and there perhaps was a correlation. So what do? Well, when HIV/AIDS came around, we decided that that was going to be a part of the situation as well, and we were going to throw in echinacea for symptomatic coughing and all of the other issues that go along with symptomology for people with HIV and AIDS. The problem with that, is it actually weakened the immune system and made them sicker faster. So we basically increased the viral load. And what that means is we increase the load of those free radicals running around, those bad cells that kill everything. We were letting those guys run rampant because we were eating on some echinacea and thought that we were suppressing an issue when really we were helping it make babies. So this is the problem with echinacea, one of the main problems. And this is the one I want you to focus on specific to this medication. Herbal medication, that is, which is a food supplement, just so I'm understood. All right, so now we're going to learn about St. John's wort. St. John's wort has been a cool thing since like the mid 90s, I want to say. It like came out as the fix your depression medication. Oh God, I want to feel like 1995, but I'm sure it was earlier than that, truly. But it became kind of big in like the mid to late 90s, and then it just became a thing. Now, here's the problem with this medication. This medication messes with a lot of antihypertensives. So what does that mean? If I'm taking blood pressure meds, St. John's wort would effectively like stop the mechanism of the medication altogether. It would rebound it and make it go higher. There were specific medications that it physically attacked in a bad way, and then some would just shut down the ability to lower that blood pressure altogether. Now, since then, there have been a million studies that say, hey, there's no correlation between one and the other. Why would you do that? So you can save the integrity of your medication and continue to make millions upon millions. Yeah, that's why they do that. So we have definitively found that there was a correlation with blood pressure thresholds that would go above the limit because of rebound pressures or because it would deactivate the mechanism of action for the medication. And also, we need to understand that the effect of this medication is a sedative effect. It's usually used to treat depression. And usually when we treat depression, ideation, suicidal or homicidal things like PTSD, things of that nature, what we're trying to do is we're trying to shut down the brain from those thoughts. Does that make sense? So if my job is to be less depressed, part of being less depressed is taking the depressive mood away. So taking that part of the brain and kind of setting it in sleep mode. And if it allows to rest, that little piece, that part of depression, if it rests and digests rather than being set on high alert, it can relax. So what it does is it does this to your brain, right? Problem with that is if I'm taking medication for seizures like, I don't know, phenytoin, like Dilantin, which require really, really tight numbers to stay afoot, or I'm taking Depakote, again, a huge seizure medication, this is going to increase the effect of the medication and could completely respiratory depress me. I'm just throwing that out there. Or, shut down my brain too well. There's that. That's also pretty scary. Again, also causes dangerous interactions with other prescription medications. Look at it. SSRIs, benzodiazepines, anticoagulants, statins, calcium channel. I mean, that's so many medications. Oral contraceptives is such a problem. So again, when you're talking about herbal meds, St. John's wort, ginseng, and golden seal are known for wrecking the blood pressure of a person who's taken the supplement. All right, so let's go to the next slide. I think we're done with St. John's wort. All right, pregnancy medications. You will not hear me talk a lot about pregnancy medications because that's baby land. And trust me, nurses, they stay in their lane, and my lane is not baby land, okay? Those are the cool professors, not me. I'm like all but peds and OB unless I have to do it, and then I can jump on it real quick. But I'm not a fan, right? Like it's going like to the National History Museum versus going to the Smithsonian Museum. Like which one am I going to go to? I'm going to go to the Smithsonian, as much as I don't want to admit that, right? Versus going to the Pharm Museum. That's not going to be as fun. This is my idea of patients regarding pregnancy. Not making fun. It's not my specialty. So, folic acid, this is what you need to know. Most important vitamin and supplement to take. Why? Well, because it reduces risk of a very, very specific problem within pregnant women. And I want you to think about what that is, and I want you to answer that question for me. If you don't know it, Google it, and then add it to your list of notes, because I'm going to actually make you do something here. I know what the answer is. Many of you know what the answer is because you too have children. So if you don't, give it a Google. Add it over to your list. There is a specific problem specific to babies that are born with a folic acid deficiency from mom. Again, let's see, teratogenics drugs are a no-no. There are a list of those types of medications. They will cause malformations or damage to the embryo or fetus. You need to stay off of them. Do we sometimes give them? Yeah, but I mean, it's a risk versus reward type of situation, so we're very careful with those things. Specific to medications in pregnancy, those are the things you need to focus on for this 3 weeks where we've been going over this material. We are going to talk more about it later, but now's not the time, so we already got enough to figure out and learn. We're just going to keep it simple. All right, more terms. The way that medications move in the body, we need to know the different types. There is distribution, absorption, metabolism, and elimination. So distribution is where we move the drug from an organ and we move it where the action's going to occur. Cool. So distribution occurs by means of blood and lymph system. Yes, it does. Yes, it does. So what does that mean? It means I'm going to distribute the medication to target the part of my body that I need a therapeutic effect on. Easy enough. Absorption. The way the drug enters the body and passes into the circulation. So what does that mean? The way the medication absorbs into the bloodstream and then circulates throughout the entire body. So a little bit different than distribution, but basically the same. Metabolism, the way the drug is altered or transformed into active chemicals. Again, we know what metabolism is. Again, it's raising action potential to create energy, right? And through that energy, we have the ability to metabolize those action potentials into kinetic energy, into movement via the metabolism. And then elimination is the removal of the metabolites. So yeah, there's that. Make sure that you understand the difference in those, and let's move on. All right, this is a public service announcement. What happens when we are not familiar with a medication and we have to give it to a patient? Oh, for the love of Pete. Here's what you don't do. Do not administer the medication if you don't know what the medication is for. You need to be prepared to tell that patient what it's for. If they go, hey, what's that medication for? I don't know what that is. Because guess what? Your patient's going to do it. And you're going to look like a fool if you don't know the answer. That's number one. Number two, it could kill them. Because it could be a mistake. These things happen. Don't do it. Number two, consult with another nurse for assistance. I don't care how long that nurse has been a nurse. I am not going to go look at Sally Joe Bobby Sue and be like, hey, you ever heard of this medication? And they're like, oh yeah, I've heard of it. Go ahead and give it to them. That don't mean a hill of beans and a circus to me. I'm just being honest. Do I even know what that means? Nope. Because that's how irrational it is to trust another person with a medication when I can just look it up. Okay. A nurse is not going to know 10,000 medications. I don't know 10,000 medications. There are more than 10,000 medications. It's not going to happen all the time. Look it up. Seriously, Google it. It takes faster. It takes less time to Google something, and it takes a faster return on an answer to Google it than to go find somebody to give you the wrong answer anyways. I'm just saying. All right. Also, don't inform the patient about the medication's potential side effects because, well, you don't even know if that's the right medication for the patient because you've never even seen the medication before. So it doesn't make any sense to you. All right. What do you check? You do check the medication level. You do compare it to the MAR. You do make sure that you look up that medication and that you are familiarized with that medication and what side effects to look for. Or you call your pharmacist and then you get the same information. But by all means, the first thing you need to do is check the medication label, make sure it's the right one on the MAR, and then from there, if you don't feel good, call a pharmacist. That's their job, is to let you know if that's right or wrong. And then they call the doc from there. They usually don't troubleshoot it to you because that's their forte. That's their baby. That's what they mess with. All right. Public service announcement is over. Thank you for your time. Okay. So, verifying meds with a pharmacist. This is also just as important as the last slide. You have to have the pharmacist verify the med before you can give the medication. Are there exceptions? Yeah. It's called ACLS protocol, which means you already know what meds you're going to get anyways, and your pharmacist is going to be at bedside during the code anyways. So it's better than having a pharmacist look at it first and verify it, because it's real time. So again, if there is a medication that your doc puts in, it could have been an accident. Remember, these guys have 30, 40 patients sometimes. I'm not even joking. Sometimes they have the entire house because there just wasn't enough manpower, and they're stuck with an entire list of patients that goes from here to Timbuktu. So it's easy to mess it up on their end, quite honestly. And you only got 5 patients. Realistically, if you're in an ICU too, the ratios are different, obviously. But you don't have 25 to 30 patients. So that's a lot to haggle with. You can accidentally, when you've got, 4 or 5 screens up and you're trying to look at 4 or 5 patients at once because 4 or 5 people are calling you at the same time, this is a realistic thing that can happen to a person very, very easily. I've done it myself. It's that easy to do. So as a nurse, when you see that code come in or you see that order come in, you're like, wait, what? This person doesn't have a history of seizures. Why are we giving them this medication? You need to call pharmacy and verify that med with pharmacy, because pharmacy is going to be doing the same thing you're doing, right? And then you also need to know that you do not administer that medication until the pharmacist goes, okay, and then checks the box. Seriously, until they dose that medicine to you or they make it available for you to pull, don't even try to override the cabinet. Don't do it unless it is an emergency med, unless your doc is sitting right there, unless you double verify it. But even then, pharmacy is going to get real tight about that not being verified first. I'm just letting you know. And I think that's all I got for this slide. So make sure you understand those 2 concepts. All right, we are creeping up into learning about medication. So what do I need for you to know about meds? All right, cool, here we go. I need for you to be able to let me know the side effects of the medications that are common. I need for you to let me know the therapeutic effect of a medication. What is the desired effect of the medication, right? So Ativan, what is the desired effect? The desired effect is I quit seizing. Or the desired effect is I quit having alcohol withdrawal symptoms, right? Things like that. The reason the drug was prescribed. Mechanism of action is what is it getting into that is stopping the effect I'm having and is fixing the symptoms I'm having, all right? As well as the chemical composition, which means what are the active ingredients in that medication specifically? I know it sounds like a lot, but it's maybe 1 or 2 words, and it's always going to be the things that are completely different than every other medication like that. So they always stick out like a sore thumb. Lasix is one that we're going to go over. Warfarin's another one we're going to go over. They stick out like a sore thumb because their side effects are so oddly specific. I am not going to test you on very common things that look commonly. They look so close in relation, it's too hard for you guys to decipher. So I'm going to make sure they are way out in the open. They're like outliers type of a deal. Remember, 80% of your meds are metabolized in the liver. So if you have a history of liver disease, you have an increased risk for toxicity of those medications and toxicity of your liver even further. Makes sense, right? Like, liver disease is a big problem if you were taking medications metabolized in the liver. I think that's pretty self-explanatory, right? So keep those things in mind as well. All right, be expected to be able to pull out how to reduce a medication error out of a lineup. All right, so med rec should be done timely, right? You need to jump on those med recs so that you know what the patient's taking, so there is no ifs, ands, or buts. That will help you reduce medication errors. Don't delay in documenting. We used to have to manual override during COVID times because they didn't want us to cross contaminate with computers and patients and things of that nature. So we would do a manual entry override once we left the room and we got our PPE gear off, right? So that became a problem because if you would chart on a PRN medication and forget to do it, then the person in the next shift could just dose it and then they could have gotten a double dose. That happened all the time. Don't delay documentation to the end of the shift. Don't delegate medication to a UAP. That's duh, of course not. How would they know how to do medication transcription? They're unlicensed. So don't do that. Limit the use of verbal orders to emergent situations. Well, yeah, I mean, if you are 6 days in a row on 12 to 16 hour shifts because you guys are going through staffing issues, which happens all the time, how in the heck are you going to remember a conversation that you have briefly with someone in the hallway to get a PRN medication, right? Like it's a verbal order that can easily get messed up. So doing that in emergent situations when there's 50 people around, that's a smart idea. Doing it when it's just you and the doc, I mean, at the end of the day, it's you versus the doc and his word against yours or her word against yours. And when the doc's like, no, that's not what I said, then they're going to pay attention to them. So just make sure that you don't do that. Also place medication dispensing systems like the Pyxis or Omnicell, put it in low traffic areas. If you stick it in high traffic areas, it's really easy to forget a medication. It's really easy to walk over a medication. It's really easy to get to accidentally and then shut it too early. And then you got to drop more medication in and recount it. Like it's a big mess. So just do it in low traffic areas. And again, be prepared to, look through a scenario case and go, okay, well, this is not a good way to prevent this medication error, or this is a great way to prevent that medication error, just depending on what that looks like. All right, so we need to talk about medication dependence. It is a thing, it happens. Psychological dependence. That is when you have feelings of anxiety, feelings of stress, feelings of angst, tension, if you do not get that drug, right? It is an intense mental desire for the drug. You could get a placebo of that medication and physically feel better from a psychological dependence perspective by thinking that you have that medication in your system. Okay? This is completely different than a physical or chemical dependence. Does that make sense? All right. It is an intense mental desire for the medication. Symptoms: pain, nausea, excessive sweating, all symptoms associated with physical dependence. This is a big deal. Physical dependence could cause people to seize if it's a serious enough dependence problem. So we need to be able to understand the signs and symptoms of that. So pain, nausea, excessive sweating, I would say also irritability, confusion are also pretty prominent ones. So keep those in mind and be able to pick it out of a lineup if you need to. All right, medication adverse effects. Remember, these are effects that we do not want because they are harmful to a patient. So here are some factors that increase adverse effects in patients, specifically elderly patients. Their kidney function and liver function. Why? Well, because if they have poor kidney and liver function and these medications are absorbed through the kidneys and the liver, obviously it's going to bust those organ systems up a lot easier, okay? Also, those medications might be more potent because the elderly person is not going to have their intestines moving like it should. So they might carry it a little bit longer. That's pretty common. Compliance to previous medications is very important because if a person is not taking their medication as it is told to take it, whether they're taking too much or too little or nothing at all because they refuse, these can cause some adverse effects, whether it be because they didn't take it, so then they get stronger symptoms, or they take too much of it and they have too much of a reaction to the medication, right? Elderly people are more likely to be affected by drug metabolism than teenagers, young adults, or middle-aged adults. Duh. Of course. Sex is also a component. Why? Well, again, metabolism works different on men versus women. So we have to take those things into consideration as well. There are other factors, of course, but these are the ones I want you to focus on. All right, so some considerations with older adults and medications. It is going to affect their entire body system by way of absorption, distribution, metabolism itself, and elimination of those medications. So make sure that you understand that those things are all intercorrelated, right? Also, um, make sure that you understand indication for administering the medication. Why am I giving it? Therapeutic goals. What's the end game? What's that going to look like? Administration routes, they're never altered by aging. Okay. Um, know that the reason that absorption, distribution, metabolism, and elimination are all affected by aging is because there is a decrease in acidic secretions that affects the absorption of the medication, and how elderly patients will hold on to that medication or metabolize that medication at a very weird rate. And why we always need to look at elderly patients completely different than we would like a middle-aged patient. All right, guys, here's the 9 rights. You need to know the 9 rights. You also need to know what the 9 rights represent. So you need to know that the right reason means the reason for administering the medication, right? You need to know that the right response means we're going to have the side effects of the medication at hand, and the right response is going to have therapeutic, a non-complicated situation, right? So we need to know what the right response to the medication is going to be versus the side effects. Right dose, right route, right time. Again, the right dose is appropriate for their weight and height ratio. It's going in the right route that is appropriate and most important to, whatever clinical manifestation they're having is in emergent medicine, or we give it to them slow, but we need to give it to an emergent, that type of deal. Frequency is, am I giving it too soon, too late, right on time, so on and so forth. So know your 9 rights, because what's going to happen is I'm probably going to put right to have no mercy. And you're going to need to be able to pick it out and say, that's not one of the 9 rights. That's stupid. That's silly. Or something of that nature. I don't know what that's going to look like exactly, but just know that the 9 rights always come back, so you need to have them committed to memory, honestly. All right, next slide. All right, going back to medication and polypharmacy, things related to taking too much of something just because you don't have comprehension. We need to understand with over-the-counter medications, again, I've reiterated this a couple of times, you have to take over-the-counter medications to the recommended dose. Do not exceed it. Patients don't know how to read the medication labels, honestly. So it's our responsibility to educate them on how to read a med label and instructions. Use teach-back method. So if somebody asks you, hey, how many of these can I take? What you need to not do at that moment is go, you just need to take 500 milligrams. It's the equivalent of 2 tabs of that medication. No, what you need to do is go, here, let me show you how to read this label. This is how many tablets you have. This is how many milligrams it is per tablet. If you take 3, how many milligrams is that? Is that too much or too little? And how often should you take it? And here's where you put that. And you show them, and you have them reiterate that back to you. Why is that important? Well, it lets us know that we're not just teaching them that one bottle of medication, because we're teaching them an entire skill of how to read a medication bottle, be it ibuprofen or aspirin or acetaminophen or whatever, right? They need to understand how to read that dose and interpret that dose and know how little they're supposed to take, how often they're supposed to take it, through what route, right? So these are the things I need for you to pay attention to regarding this slide. All right, so everyone's favorite, types of injections. I need for you to know the following. I need for you to know what injection goes at what angle. These are absolutely going to be questions that pop up. I'm just being real. It might not be today, it might not be tomorrow. They're going to come up. You're going to need to know that an IM injection's 90 degrees. Not 25, not 10, not 45. It's got to be 90 degrees, because you trying to get into the muscular area, and you ain't going to get into the muscular area going at a 45-degree angle if you ain't got a good enough gauge. And even if you do, why are you trying to go to a 45-degree angle? You need to go straight down. All right, things of that nature. You need to know that. Types of injections. You need to know the difference between a sub-Q injection versus an IM injection. You need to know what angle it goes at. Duh. You also need to know regarding the injection sites. What sites are good and what sites are not. So if you have, I don't know, like an IM injection, you do not want to stick that in the dorsal gluteal area. Why? Well, look down at the dorsal gluteal site. What is around there? Everything, nerve endings. If I hit the wrong one, you've got sciatica for the rest of your life. I'm not trying to push a whole bunch of stuff in there. Also, we need to know what's the maximum volume for the area. So if I do ventral gluteal, which is what I'm supposed to do, I'm not going to push anything in excess of 2.5 milliliters. Otherwise, I'm going to have to get a second injection. All right. So what does 2.5 milliliters look like? You also need to keep that in consideration. So dorsal gluteal, nope. Ventral gluteal, sure. Because there's not a whole heck of a lot around there. So there's not a whole heck of a lot you can mess up. Make sense? Cool. So just take an eye to this slide and note those little silly things. I'm not so much worried about you looking at how much mLs. I'm not going to be like, hey, the deltoid you can only do 1 milliliter. Those questions are going to come up, but not like, it's not going to be quite that hectic right yet, but it's about to be. So go ahead and start committing those to memory now if you can, because there's going to be an example where someone's like, hey, and I'm just theoretically throwing it out there, hey, which action by this nurse is inappropriate and requires immediate action? That's usually how they, have the verbiage for it or something along those lines. So you need to be able to look and go, dude, you're not going to stick 5 milliliters in a delt. That needs immediate intervention. There you go. Boom. There's your answer. So you need to know what those numbers look like. All right, next slide. All right, so these are needles, and these are the needle gauges, and these are pretty comparable to the actual sizes, if I'm honest. So there's 3 ways we look at this. We look at this from a color perspective because that helps us remember. A way that I always do it is I'm like, blue 22, blue 22. So I know 22 gauge is always blue, right? I always think of people who go to Starbucks and they like to get a venti frappuccino, which is 20, and girls love to go to Starbies. So there's my correlation with pink and a 20 gauge, right? An 18 gauge, I think of the Hulk, because I'm swole. And usually the 18 gauge is about the biggest we're going to have on any basic unit. So I always ask for the Hulk. And they're like, yo, you about to put an 18 in there? And I'm like, yeah, I'm about to put an 18 in that, right? Like, it's just funny, haha. Now, as we go up in the number, so 22, 24, 26, the smaller and the thinner we're going to get on our needle, whereas the lower number, like the 14 gauge, the 16 gauge, the 18 gauge, the Hulk, those guys are going to be a lot chunkier and funkier. So when we're dealing with a baby needle, I'm going to make sure I'm not putting a 14 in that. That is a no-no. I'm going to be doing a 24, a 25, a 26, things of those nature. Or things of that nature. No baby sizes are going to get teeny tiny, but again, look at the size of it. I mean, is that appropriate? The size of a hair for a little itty bitty teeny tiny infant? Yeah, for sure. So know that bigger gauges mean smaller needles, and smaller gauges mean big old fat needles. Big old fat needles. It's like Forrest Gump. There was sideways rain and big old fat rain. Big old fat needles. Okay, moving on. Friends, until the cows come home, we are always going to talk about medication administration and 2 patient identifiers. What does that look like? Well, you got 3 options, friends. Patient ID number on their armband, their full name, their date of birth. Can't really deviate from that. So, know those silly 3 things and know how not silly they truly are, because we do silly things all the time because we don't check patient identifiers. So there are your options. Next slide. Medication compliance is such a big deal with patients. It is, because patients lose their autonomy when somebody goes, you need to do this or you need to do that, which is why rapport between patient and provider is so important, right? And while we are so serious about customer service nowadays, because the doctor used to be able to just run through people and nobody could do anything. Nowadays, that's a big old not gonna happen. So it gives us an opportunity to check the integrity of the doc, which is cool, but it also gives us an opportunity to make sure that we are following compliance. And part of that is creating a bond between, again, patient and provider, and going, hey, look, Mary Jo, Susie Q, I need for you to understand that, like, you and your kids are not going to be in a cohesive space right now if you're not taking your medication, because you are going to be severely depressed, and you are going to be in the bed like you told me, and you are going to sit there and wonder, can I wait another hour, or should I just go get up and go pee? Because that act just to move that 12 feet is so much that I can't even deal, right? That's how big of a deal this is. So we need to make sure that we have an understanding that medication compliance is important, and our patient is going to adhere to the healthcare provider's recommendations. And so long as you get that, that's all you need for this slide. And also know what it takes in order to be able to bend and yield and compromise like that. It's a big deal. All right, I've touched bases with this before. Medication non-compliance. Most people who are non-compliant because of ignorance, not because they want to be a jerk. Okay, it's not. I've known a ton of patients. Some of them are like, I'm not taking it, and this is why I'm not taking it. And I find out, and they're like, I got nothing to lose. I'm going to take this med. It's going to make me sick. I don't want to be sick. I would rather not take it at all. At that point, I'm their biggest cheerleader because I totally get where they're coming from, right? So again, ask them why they're refusing the medication. 9 times out of 10, it's because they don't realize how to do it, or they feel inferior. How dumb would you feel if someone gives you an insulin syringe and says, hey, stick yourself in the abdomen, and you can't see? You can't see to see how many units it is. When all I got to do is get you a little twisty guy, right? And you can see the 2 and the 3 to know that that's 2 and 3 units. Cool. Like, just let me know. A lot of times it's something that silly. If a patient refuses the medication, you have to notify the healthcare provider like right then and there. Why? Because maybe they're cool with a different derivative. Maybe the doc can talk him into taking his medication like he's supposed to. Who knows what the situation is? But a lot of times, if you don't let that doc know and he finds out later on, and maybe he's already like rounded on that patient and won't see him until the next day, and then they're like, I ain't taking that medicine. They're like, what do you mean? That's your blood thinner. The heck are you talking about, right? If one of those happens, it gets really, really hectic, and it's on your side and it looks really bad on you, and you got to deal with a lot of shenanigans. Or you could just do what you're supposed to do and do the right thing and call the doc. And that's that. So just know those things. All right, so let's go back to pain assessments really quick. Pain assessments are meant to track the level of pain prior to a medication to determine baseline of that patient's pain level, right? Then what we do is we do an assessment again after they've had that medication, usually after about an hour after if it's oral, half an hour if it's IV. And then you do a secondary pain assessment, and that will determine the level of functionality or therapeutic level of that medication. So if Sally Joe Bobby Sue Smith Reeves Baker Jr., if that person says, hey, I'm an 8 out of 10 right now, and then I'm like, here, have some morphine, and then I give it, and then half an hour later I come back and I'm like, hey, Sally Joe Bobby Sue Baker Reeves Smith whatever Jr. I just said, how are you feeling? And they're like, hey, 2 out of 10. I'm like, yeah, therapeutic effect met. Cool. You should always have a nursing goal or a patient goal for pain level. That would be the level with which they don't need any more medication and they're comfortable at that level. So for some people, it's like a 4. Like, I'm not going to call you if I'm a 4, but if I get to a 5, I'm calling you for medication, that type of a deal. So know that if someone has a pain level, we need to do a pain assessment and then a post-pain assessment or pain medication assessment or update. That is a focused assessment because we are focusing on their level of pain versus a full assessment, which is a head-to-toe assessment. And then we will do a quick pain scale to summate, is it getting better? Is it getting worse? Is the medication working? That type of a deal. All right? Oh my God. I need for you to understand that do not stop taking medications if the patient has side effects. Again, there is a difference between side effects versus adverse reactions versus allergy versus anaphylaxis. All right? Big deal. You have to educate the patient. If you are taking this antibiotic and you get stomach upset, cool. It's supposed to do that. Okay? So I need for you to continue to take that medication until all that medication is gone. Now, if they have anaphylactic effects, which means their throat closes up, that's obviously different. We're going to have hopefully a signal or two before we get to that level of all right? But by and large, If they are having side effects, they need to be educated. Dude, completely normal. You have to keep taking the medication. You have to talk to the healthcare provider. Even if they're having side effects, you should not just stop taking those medications. Why? Well, because of superbugs, that's why. And about 50 other million reasons that have to do with 50 other disease processes, but that's the first one that I thought of. So keep that in mind. Inside the house, we were playing back. Sure, Mommy's recording. Give me just a second, okay? All right. Sure, Mommy's recording right now. It's okay. Give me just 1 second. Okay, really quick. Half-Life. Sorry, kiddo just got home. She's pretty excited to tell me how her play date went. Okay, cool. So understanding Half-Life. Here's the deal. This is so simple, but it looks so complicated. All Half-Life is it's showing me how much medication is in my body after a period of time. So the Half-Life is, it shows me to what level or how long does it take to get to half of that dose of medication from the moment I got 100% of it. That's all it's saying. So if the half-life is 50 minutes, that means I have 100% of the medication in my body at 50 minutes. And then after half of that time has passed, again, we're at 100 minutes, so like just double dose that time. After another 50 minutes has passed, I'm down to half of that medication. So I'm 100% of that medication when I'm dosed it. It takes 50 minutes to get into my body. Okay, so effectively after the first 50 minutes, I've got the medication in my body. After the next 50 minutes, I am at 50%. At 150 minutes, I am at 25%. Does that make sense? Usually by the third pass, the medication is completely inactivated out of our system. Okay? That's all a half-life is. So if this number was, I don't know, your half-life of 70 minutes, the medication's effects are going to last 140 minutes. Because at 140 minutes, I'm going to be at 50% of that medication in my body. Got it? Okay, cool. That's it. All right, so when we're talking about medication routes and absorption, you need to know the IV is the fastest route. Transdermal is usually the longest. I want you to just look over this and go, okay, fastest intraosseous, intravenous. Okay, that makes sense because it's going directly into, the area of circulatory systems, right? Endotracheal, 2 to 3 minutes. All right, cool. Inhalation. All right, cool. Both of those are inhalants. That makes sense because it goes right into my lungs. And okay, cool. That makes sense. So I need for you to just kind of go through it very quickly, understand what that looks like, and have a generalized idea. But again, IV is the fastest route. Everybody knows that. Slowest route is transdermal or topical. And again, understanding like the parameters of high and low is generally where you start. And then if you see anything that looks super funky that you might need to know, put that into consideration. But yeah, just pass over it really quick, understand the basic concept, and move on. All right, now on to true drug allergies. It is an immunologic response to the drug. So they're going to have angioedema, rhinitis. They're going to have tearing, nausea, vomiting, wheezing, dyspnea, diarrhea. So big problems. The first thing you need to do when you notice any of these signs and symptoms in a patient is stop that medication, that antibiotic, that antiviral, that blood, whatever it is. Stop it to prevent further complications. Call the physician. Let them know after you've stopped it. But first, stop it. Don't keep it running. Hello. All right. This is different from a drug allergy is different from an anaphylactic reaction. What's an anaphylactic reaction? Well, it's worse. It's worse. It's where organ systems shut down, throat shuts down, circulatory and regulatory function shut down. That's anaphylaxis. All right. So we're nearly there when we have a nasty drug allergy, right? Nearly there, but we still have some wiggle room. So let's make sure that we don't get to anaphylaxis by way of turning the junk off and then calling the physician to figure out how to reverse it or stop it dead in its tracks. All right, first pass of medications or first pass effective medications is basically when the first time you take it, it's known to metabolize so fast within your body that you can't get the right concentration of medication within your body system until your body is used to taking that medication. I know that sounds very bizarre. So what we have to do is this is for intraoral route only, or what they call oral route, right? So for integral medications only, a lot of times we have to change the route of that medication due to its first pass effect. If I take it, it's going to metabolize so fast that when it finally gets to circulation around my body, it's going to be such a weak amount that it's not going to do what it needs to do. So what you need to know about this is oral drugs are most affected by this. The other ones, inhalation, intravenous, subcutaneous, they're not likely to have anything to do with the first pass effect whatsoever. So those are the pieces and parts that you need to know. I've added some additional information just for clarification, just in case you need it. But other than that, we'll move on to the next slide before my voice goes away entirely. All right, high alert medications are so serious that they could kill a person. So what we have to do is we have to get a double verifier from a medical professional. So what's going to happen is we get the order for this highly concentrated insulin or for this PCA pump, right? Highly concentrated insulin sometimes is anywhere from 5 to 10 times stronger. So 1 unit of regular insulin, what we would do is we get highly concentrated, and 1 unit of that highly concentrated would be the equivalent of 5 or 10 regular units, right? So you'd have to have a nurse verify it after 2 pharmacists have verified it a lot of times. So they'll make it in their area. They will have a secondary pharmacist double check that. Then they give it to us, and then we have to double verify it with a nurse because, again, it's that serious that somebody's going to get hurt if we don't regulate it and check it off to make sure that it's absolutely what we're supposed to give. And usually those medications, you're going to stress to give it to a patient the first time if you're the first dosing nurse. And you are just going to monitor that patient like crazy. And then obviously after the first dose is done, you know kind of how that looks. It's a lot easier to deal with after. And again, much like high alert medications with black box warnings are the highest safety related warning for medications. So again, what we're going to have to do with black box warnings is monitor that patient like crazy because, well, they could die. There's that, or they could be permanently affected by this medication. They could stroke out and never be able to move their body again because they took this medication. So we absolutely have to monitor our patient. And usually with these drugs, we go what's called low and slow. So we'll start off with the smallest dose, and then just kind of bump our way up as needed, right? Because again, black box warning is a big deal. So you need to know what the definition is, and you need to absolutely know that we got to monitor these patients like a crazy person because things can go bad really quick. All right, guys, we're finally on official meds. So let's start off with digoxin. Digoxin is what we usually call DIG. It's used to treat heart failure. It's also used to treat really, really high heart rates, right? So chronic atrial fibrillation is a big one. I've seen people in AFib and it bumps from 86 heart rate, 129 heart rate, 161 heart rate, 121 heart rate. And this is the monitor, constantly bumping up and down. And it's because we have a turbulence within your heart rhythm that is just kind of sporadic. And it's like somebody just doing, oh, that's okay, cool. All right, so I'm not going to encourage you to watch this movie because it's obviously, an adult movie. But like, if you've ever seen Step Brothers, at the very end of Step Brothers, he does like this huge like drum solo riff, right, at the Catalina wine mixer. And his drum solo would be the equivalent of what I would interpret as atrial fibrillation. There you go. That's exactly what a heart sounds like with AFib. DIG toxicity, it can manifest in bradycardia. So if you have a patient who's on DIG normally and you go to check their heart rate and the heart rate's like 58, you might want to do a DIG level because if you haven't dosed that medication and it's been a solid, 8, 12, 16 hours and it's time for another dose and we are in a situation where they're already under 60, which is why you have to check a pulse, an apical pulse for an entire minute to make sure that it's above that 60 threshold. You're not giving them that medication. If it's less than 60, you put it in and notify the doc that, hey, listen, our heart rate's like 57. I'm going to hold the DIG, and they're more than likely just to get a level right there. So that's what we need to focus on with this medication specifically. What it's used for, it's used to treat heart failure. It's used to treat atrial fibrillation or other rhythm issues. Um, Again, if it manifests in bradycardia, there is a high likelihood that there is a toxicity, so we need to check that level and do not give that medication. Done deal. All right, so the only thing I need for you to know here, because I know these are some pretty hard definitions down here, all I need for you to know is what it does. That's it. So here, decongestants, what do they do? They relieve nasal congestion. Antihistamines, what do they do? They decrease the allergic response. Beta blockers, what do they do? Big words for they lower blood pressure. Parasympatholytics, what do they do? Big words for it shuts down the parasympathetic response. So that all the other responses that are left is bronchodilating so that I can breathe better. It raises my heart rate if I'm bradycardic. It will, if I have gastric ulcers, it will lower my gastric acid secretions because remember, when the bear's running after me, I don't have time to poop and pee. So therefore, all of that shuts down temporarily. So if I have a bleeding ulcer, it will lower those secretions so that my ulcers can rest. That's what it does. That's all you need to know. The big words are here, specifically beta blockers and parasympatholytics. Those are there so that you, when you see them in your next classes, because you will, when you see exactly what it is that it does and how it works, you don't freak out because you're like, I've never seen this before, because here it is. Now you got it. So calm down. Just know what it does and move on. And then we're just going to do the same thing again. So a mucolytic takes care of mucus. An antitussive prevents coughing. A steroid reduces redness and swelling. Antifungals, bump it they treat fungal infections. And bronchodilators, again, they expand the airways of the respiratory tract. Done. Okay. So when we're dealing with NSAIDs, so NSAIDs are non-steroidal anti-inflammatory drugs. All right, so NSAIDs, they increase the efficiency of many antihypertensive drugs and most diuretics. What does that mean? That means if I'm on an NSAID, it's going to increase the efficiency of those medications, which means I'm going to get more of an effect from them. So I have to be really careful with that. NSAIDs increase the risk for bleeding. NSAIDs are known for doing this. It's just what they do. It increase the risk for bleeding big time. So if I'm on aspirin, hey, guess what? It's going to increase the risk for bleeding because it's aspirin. So that's what it does. Ibuprofen, naproxen, Voltaren. There's a whole milieu of them. Do you need to know which ones they are? I would put, if I were you, aspirin and ibuprofen, naproxen, because those are the most known. And then leave it at that. They increase the risk for bleeding in clients who are taking any anticoagulants. So if I'm on Coumadin and I'm taking NSAIDs, it's going to increase the risk of bleeding, obviously, because I'm taking two things that are going to make me bleed. So that's kind of how that works. Here's important. Decrease the risk for hypoglycemia in NSAIDs. So I also have to watch my blood sugar because my blood sugar might be a little bit higher than normal. So what does that exactly look like? Am I high enough to where I'm not going to be damaged by it? Or do I need to have a little more correction for that? And then, of course, if you take alcohol with NSAIDs, you're going to increase your risk for bleeding yet again. So that's what we need to know. NSAIDs, bleeding, aspirin, ibuprofen, naproxen, which I used to call naproxen, and it increases the efficiency of antihypertensives and increases the risk for bleeding for sure. And stay off of the alcohol because you're just asking for a GI bleed. All right, now we're going to talk about antivirals. Here's the fun part about antivirals. VIR in the middle. That means VIR at the end means it's an antiviral. You need to know which antiviral because there are certain ones that work for influenza. There are certain ones that work for like herpes simplex. So valcyclovir is going to be used to treat herpes simplex. And then oseltamivir is going to be for influenza. And I think, yeah, that's it. Again, VIR for viral. Anytime you see VIR at the end, that's a antiviral. Done. All right, let's talk about Lasix because that's all you're ever going to talk about. And I swear it feels like Lasix is one of the top 5 medications we talk about in the entire nursing program. So just get used to this medication. Lasix is also known as furosemide. It is a loop diuretic. What does that mean? It means it goes through the loop of Henle, which means you're going to excrete things out your kidneys. All right, and specifically this makes you pee like crazy. What do we use it for? Well, we use it for congestive heart patients mostly. because they have this crazy pitting edema. They can't breathe very well. And as soon as I give them this Lasix, it comes straight out. And all of a sudden they sound clean again. And that's nice because I need lungs that aren't covered in fluid. That would be cool. So what we're going to do is also understand that we have to monitor potassium levels. Lasix is known for making people drop potassium very quickly. And why is potassium so important? Well, if your potassium gets too high, you could die because your heart stops, because that's what we use for lethal injections, is potassium chloride. Or if it gets way too low, then you're also going to run into the same problems, right? Only going to run into problems that are going to be a little bit more significant. And we're going to get into that medication for the next examination. So for right now, I need for you to know, Lasix is used as a diuretic. It's used for patients with congestive heart failure, okay? It causes hypokalemia or low potassium, and we have to give them supplements. Like, you have to. There's no way around it because it's absolutely going to happen. And then you need to make sure that you take it with liquid if you take potassium supplements, and the liquid would have to be water. Because these potassium pills are really weird. As soon as you put them in your mouth, they start to dissolve, and they actually gag out a lot of people. So what I tell them to do is get water in your mouth, put the pill in your mouth, swallow, and then drink at the same time. So that way you can get it down there a little bit easier. So those are the most important things you need to learn for right this second regarding Lasix, and we're going to get into it a lot more for our next set of classes for our second exam. All right, so albuterol is a bronchodilator. It is usually dosed out of a MDI or a metered dose inhaler. You need to make sure that when you're using a bronchodilator with a metered dose inhaler, that you hold your breath for 5 to 10 seconds after inhaling the albuterol to help ensure the medication reaches your lungs effectively. We use spacers, and the spacers are important because it releases the medication in really small particles so that you can inhale it deeply. So what you do is you spray it into the spacer, which is like a little cylindrical device that you just breathe in out of one end, and then you stick your meter dose inhaler into a small hole on the other end. So you go pop, pop, hit it twice, let it sit there for a second in the chamber and cover up the mouthpiece of it so that it doesn't escape out of the chamber. And then very slowly you blow until it gives a small faint whistle, and that's how you know you're getting it really well. Then you hold your breath for 5 to 10 seconds or as best as you can, and then you exhale it. So that's how that works. Now, it is also known to cause, albuterol causes hypokalemia. So what's important is if we have a patient who already has low potassium because they're getting an incredible amount of Lasix, which happens often if you think about it, we would definitely need to make sure that we're monitoring those levels as well. So we would never dose these to a patient who has a known problem of hypokalemia, because this is just going to lower it even further. All right, nebulized racemic epinephrine. It is a medication that is used for moderate to severe croup. Croup kills babies. Does croup kill a lot of babies? It used to, but now that we have medications like this, it does. And I think the mortality rate is less than 0.5%. But before we had these medications, it was pretty substantial, because what happens is in croup, you will cough and cough and cough and cough and cough. And I know we've all had it before, right? The problem is with babies, they can't catch their breath, and then they go blue and pass out. And then sometimes they don't make it. I actually had my first child who had croup and was about, probably 16 weeks old. Yeah, she's probably 4 months old. Yeah, that's about right. About 4 months old, 3 or 4, and had croup. And I was literally in the doctor's office in the urgent care, and it was so bad. It just sounded like just nasty stridor. And we're going to talk about stridor later. Stridor is a very scary thing. So she couldn't catch her breath and literally passed out and turned blue right in front of me. And I freaked out and ran down the hallway with her and her, just lifeless body, right? That was a moment. Okay. That was a deal. Nebulized racemic epinephrine would have taken care of those issues. That would have not caused so much inflammation from all that coughing and not being able to catch your breath, because it would have bronchodilated very quickly and made it easier to breathe, right? So a couple of things you need to know. How do I memorize nebulized racemic epinephrine? Cool. Think of a baby, and think of racing to hurry up and get them some relief. Okay. Think of my baby and me running down the hallway at a very, very young age. I was a kid myself, to be fair. And I'm running down the hallway, and here is this lifeless thing bouncing around as I'm trying to scream to go find somebody. I mean, that was a moment in history I will never forget and is always burned. And now you will never forget nebulized racemic epinephrine. You don't want to use albuterol with these guys. You want to go straight to the highs, go straight for this stuff because that's going to take care of the issue. All right, we got oxymetazoline. It is a nasal spray. Nasal spray. It is a nasal decongestant, so it gets rid of your nasal congestion. It should not be used for more than 3 days, because if you use it for more than 3 days, then you get rebound congestion. So it gets so used to doing its effect that if you continue to take it, it makes it even worse. I know people who take Afrin religiously, and they started doing it back in the 90s, and it causes more problems than it fixes, because you should never use it long term. Discontinue the medication for several days in between so that you could get its effectiveness again. So that's not a good recommendation. It's just for temporary relief. So just remember those things. Do I have a hack for this medication? Not really. Oh, maybe. Okay. So Oxy, look at the Oxy in the very beginning. I think of OxyClean, and OxyClean makes my laundry smell better. And it also makes it cleaner because it gets rid of all the stains. So there you go. There's your hack. Done. Deal. Perfect. Go. All right, Benadryl. We talked about it earlier, about its expected side effect of being sleepy, because that's kind of what it does for most people. Benadryl, what do we need to know? Well, it's an first generation antihistamine, which means it's going to take care of allergies. It also causes potentially drowsiness and CNS depression. So do not operate hazardous equipment when taking this medication. It's going to make you sleepy. You don't want to do nothing stupid. Okay, next slide. All right, so warfarin or Coumadin, it is anticoagulant, so it is meant for you to have very, very thin blood. It is for patients who have had massive heart attacks, massive strokes, things of that nature. It interacts with vitamin K, so patients are not allowed to eat anything with a lot of vitamin K in it. What the heck has a lot of vitamin K? Well, it's easy. If it's green and leafy and a vegetable, it's probably a no-no. So spinach, broccoli, kale, turnip greens, Brussels sprouts, collard greens, and then things like eggs, lettuce, blueberries, carrots, sweet potatoes, right? Soybeans, asparagus, chicken has a lot of it. Liver has organ meats like liver, stuff like that. Back off of it. Okra is another one that's kind of bizarre. Yeah, that's basically it. So I think I've named all of the main ones. But what you need to know, because I'm not going to ask you specifically which of those foods. What you need to know is foods high in vitamin K is a big fat no-no. That's it. You can take this medication orally. That's how we usually take it. Do not take this medication with grapefruit juice. Grapefruit juice is going to lower the absorption of the medication, thus not giving you what you need. Thus you have thicker blood, right? So like, why would you avoid foods in vitamin K and then drink grapefruit juice to take it? Because it's the same thing. It's just the same thing. I get so frustrated. Okay. Digressing from my craziness, do not double the dose if a dose is missed. That is a very, very silly idea when referencing warfarin. Do not discontinue the medication if bruising occurs. Why? Because it's an anticoagulant. It is meant to make your blood thin, which means if you get hit with something, you're going to bruise, because that's what it does, right? That's the whole point of it. So that's all you need to know for this slide, and we'll move to the next one. All right, let's talk about vitamins, fat versus soluble. First off, if you ever have a choice to pick something that's asking you is a vitamin fat soluble or water soluble, if it's fat soluble, you've only got 4 options. You ready? A, D, E, and K. A, D, E, and K are fat soluble vitamins that are very specific, because those can cause toxicity because they absorb in your fat. So if you have an excess of, fat, it is going to hang out there and it is going to be a lot harder for you to excrete them because they hang out in the fat. I say it 5,000 times because people always miss this. This is the easy question, the easy points to make, and this is going to be for the rest of your program. You need to know this stuff. So fat soluble vitamins A, D, E, and K, they're all present, or they all present risk for toxicity. So I've made you a pretty new mnemonic. All dorks eat keto. Did you get it? Because keto is basically a fat-based diet, right? Where you just eat pork rinds all day and Slim Jims, and that's going to make you lose a ton of weight, sure, but then you're going to, have sludge and plaques in your arteries, which is really bad. I would rather be overweight than have a terrible heart. Okay, cool. So we just did that. So that's how that works, and that's why I made a joke. And yeah, there's your slide. All right, everyone always talks about B12 because B12 is known to pernicious anemia if you have a massive deficiency. It is decreased red blood cell production. All right, so what does B12 have to do with red blood cell production? Well, funny story. Vitamin B12 is needed to form red blood cells and DNA. So if you don't have enough B12, that's a big fat problem. People who have B12 deficiencies are people who have full gastric bypasses. They lose their intrinsic factor in their body, which we don't need to worry about right this second, but you will need to know it for your program for sure, because it's going to come back in every single class. This is another one of these medications that come up directly related to GI conditions and also conditions of anemia. So B12, it can lead to pernicious anemia if you have too low. If you have gastric bypass, you have to take B12 for the rest of your life. Why? Because it forms red blood cells and DNA. That's a big deal. All right. So just know B12, pernicious anemia it can cause. Know what it's for. And yeah, you should be good with this one. So let's talk about the underdog of the vitamin world, which is zinc. So zinc is a big deal, and we found that out when COVID happened and we thought there was an apocalypse and everyone was going to go, right? And a lot of people did, to be fair. It was not my favorite time in the world dealing with all that. So zinc is absolutely amazing. Here's why. It is a major player in DNA synthesis. It is about growth of cells. It helps build proteins. You ready for this? Wound healing. You get some wound healing, and you get some wound healing. You all get wound healing. I just Oprah'd the situation out. So, wound healing, very important. Why is this important? Well, when you're in a hospital setting and you have patients who have really severe stage wound ulcers, that's everything. When you have a patient who's a diabetic that can't get it together because they can't lay off the candy bars and they don't take their medicine, again, wound healing. This is a big serious situation here. Zinc became a big player in the hospital. And I remember seeing zinc for the first time when someone was a COVID patient and they had it on the list of medications. And I looked at him and I said, for real? Zinc's gonna save the apocalypse. Yeah, sure. Okay, fine. And then I got to looking into it and I realized how important this really is. It heals damaged tissue. It supports a healthy immune system. Friends, if you are sick because you were stressed out in nursing school, you take your flipping zinc. You think I'm joking. When COVID hit, I bought 4 bottles of zinc and put them in the nursing station. So whenever anyone needed to come in, the first thing I would say is, did you take your zinc? And they would roll their eyes and look at me, and we all started taking zinc because it was really, really cheap at the time. It was like $2 for a bottle maybe, because nobody knew it was a big deal yet because, COVID had just started and we were all working in the hospital. I took it religiously, and I still take it religiously to this day. Let me tell you, if I get sick, I may be sick for a day. That's it. And I swear it's because of zinc, because I went through the entire apocalypse of COVID. You ready for this? Never got it. Not once. Never had a symptom, never got sick, never got nothing. And I was literally in the ICU in the room with these patients, sometimes without an N95, because remember, in the very beginning, we didn't have a lot of supplies. And when your patient's taking their last breath and there's no N95 that you could grab because we're waiting for another supply to come in, do you think I'm going to wait outside the glass while they pass? Nope. I'm going to jump in there with them because the way I figure it, I probably already have it anyways, right? I need for you to understand, if you've ever seen Stephen King's The Stand, that's exactly what it was like. That's exactly what it felt like some days. And I was Gary Sinise, who is the main guy who just never got it, and people were trying to figure out what was different about him, right? It was just genetics, I suppose. So I go off about zinc a lot because you need to know how important this is, specifically for your patients, because we have a lot of patients that do not have zinc on their roster of medications, and they've got stage 3 pressure ulcers. Now, is it going to fix it and make it all better tomorrow? No, but it's going to support the healthy growth and replication of those cells as appropriated. It's going to help their immune system so that their infectious process is going to be a little bit less of a disaster than anything else. So, okay, I'm done talking about zinc after 3.5 minutes. All right, so I gave you a couple of things here about food and beverage things we need to be considering. Again, grapefruit juice is a great source of vitamin C. However, it interferes with the effectiveness of many medications. So don't drink it when you're taking medications like, I don't know, Coumadin. There's a big old fat list of medications. There's many antihypertensive. There is antiretroviral medications for HIV that you don't want to take with it. There's a whole list of them. Oh, I looks like I put it down there for you as I'm sitting here not paying attention to my slide and just kind of rattling off. Cool. So there's your list because I was smart. Antihistamines, cholesterol lowering drugs, HIV drugs, transplant drugs. There are many more, obviously. Reduces the absorption of drugs if you drink grapefruit juice. We usually ask them to do orange juice instead for a good source of vitamin C. Warfarin and green leafy vegetables. Again, Coumadin, don't touch green leafy vegetables because it is going to lower the effectiveness. And yeah, that should be good. All right, finally, I made a med error. What do I do? Oh my God. Does a nurse make a med error? All the time. Have I made med errors? You bet your tail I have made med errors. It happens, okay? Like, I love how we talk about, oh, I'm a nurse, I don't mess up, I double verify and check everything because I'm perfect. Look, when you are exhausted and you have literally done, you ready for this? Here's my record: 26 12-hour shifts in a row. That is my record for number of shifts I've had to do in a row. When you're on day 26, you are barely even moving. If I'm honest, your entire body aches because when you were up in a hospital setting, you were never sitting down. Now, I know everyone's like, oh, I know lots of nurses that sit down. Cool. I am not they. My patients are my family. Remember, guys, I don't have any family left. I got me and my girls, and that's it. So my family has become my patients because I want to make sure that they're going to be safe because they're a part of my legacy that I leave behind. Just like you guys. When I'm dead and gone and over, you guys will continue on that mantra of take care of humanity, fight for humanity. Why? Because I've instilled it in your brain, or at least I've had a small moment in that time of teaching you how to be a super nurse. So it happens. What do? You assess your patient and check the vital signs first. What do you not do? Don't go apologizing to the family and going, hey, I just made a grave error. You are asking for trouble. It might not be that big of a grave error. You need to think about what you were doing and first take care of your patient. Do not go and call the doctor and be like, yo, I made a med error, because you need to check on your patient. Do not go to the charge nurse and tell them that you need to have a sheet and follow protocol for administering the wrong medication. You need to check on your patient. Do not sit at the nurse's station and document your med error. You need to take care of your patient. Most importantly, do not try to hide it. Much like the Fugees tried to tell you, ready or not, here we come. You can't hide. I'm just telling you, don't do it. Because if you really, really, really want to get in a lot of trouble and get fired and potentially go to jail, just act like it didn't happen. You have got to admit your mistakes and hold yourself accountable for the sake of that patient. Okay, I'm done. I'm not gonna yell anymore. I'm done. I love you. All right, we are at our last slide. You guys can do this. Focus on what's important. Remember what I told you guys. Remember what I told you in class. If there is something that stands out to you, pay attention to that and focus on that. Listen to my shenanigans for 102 minutes or 103 minutes. take a deep breath. We're going to go over this material again. We're going to have another review on the days that we've allotted to make sure that we go over this material one more time orally all together as a team, as a family, so that we can take a deep breath, get in there and do a great job, okay? All right, happy studying, happy Saturday, and it's going to be a great day. It's going to be a great day, friends. Just take a deep breath. I got you. I'm proud of you. I love you all. I'm so proud of you. So proud of you. You guys are so freaking smart. Like, this is the coolest cohort that I have ever had, and it's my first LPN cohort. I've been begging to get LPNs for a long, long time, and I just love you guys to freaking pieces. I need for you to know that, because, I'm all rawr, tough, apocalypse, fight. But the fact of the matter is on the inside, I got nothing but love for you guys. For real. I'm like Heavy D. I got nothing but love for you, baby. So remember these things. I'm proud of you. You're smart. You are worthy. You are good enough. You are talented in your craft. So deep breath, take notes, eat lots of snacks, right? Freshman 15, it's cool. Let it happen. And then we'll see you at the exam.